Okay. Hello, dear doctors. Here we are going to explain another question about cardiology. A 25-year-old male presents to the accident and emergency with a complaint of substernal sharp chest pain. The patient claims that the pain is such worse on inspiration. His past medical history is insignificant. However, he smokes 20 cigarettes daily and drinks 50 units of alcohol weekly. On examination, his chest is clinically clear and his abdominal examination was found to be normal. His vitals are noted as temperature 38 degrees Celsius, respiratory rate 18 breaths per minute, blood pressure 110 on 70 millimeter Ag, oxygen saturation 97%. What is the single most likely diagnosis for these patients? As we can see in patient history, he has substernal sharp chest pain and he is febrile, but there is no any other significant thing in his history. And we will evaluate the choices. A. Myocardial infarction. B. Pericarditis. C. Pulmonary embolism. D. Pneumonia. E. Esophagitis. If the patient has not any obvious thing for pneumonia in auscultation and exam, we cannot find any obvious thing for the patient's pneumonia, and the only thing with the patient is with the substernal chest pain and fever, we can choose pericarditis, and we'll explain it why we choose pericarditis. This is simply a diagnosis of exclusion. In pericarditis, the chest pain felt by the patient is pleuritic and aggravated by inspiration, coughing, and a change to the upright position. The pain is relieved when the patient lies down. The diagnosis of pericarditis involves the typical chest pain, pericardial friction rub on auscultation, and characteristic ECG changes. With this question, STEM only gives one part of a clue for diagnosis, which is the pleuritic chest pain and air fever. And here we are going to explain a little more about acute pericarditis. Features of acute pericarditis. Chest pain is described as sharp, stabbing central chest pain with radiation to the shoulders and upper arm. Chest pain may be pleuritic and is often relieved by sitting forward. Chest pain may be made worse by inspiration, cough, swallowing, or movements of the trunk. Other symptoms include a non-productive cough and dyspnea. Pericardial friction rub on auscultation. Clinically, the presence of a pericardial friction rub is pathognomic. Often a rub can be heard even when a pericardial effusion is present, and causes of acute pericarditis. Viral infections like Coxsackie virus, tuberculosis, uremia causes fibrinous pericarditis. Trauma is one of the common cause of acute pericarditis. Post-myocardial infarction and like Dressler syndrome, we must concentrate on this point. It's very important point when the patients had previous MI and now is coming with acute pericarditis or Dressler syndrome and connective tissue disease. ECG change. We have some significant changes on ECG, and we will explain in the below. Widespread saddle-shaped ST elevation. Saddle-shaped meaning concavity directed upwards. PR segment depression and diffuse T-wave inversion. And here are ECG for acute pericarditis, and we will explain here. As we can see in this ECG, it has widespread ST elevation. As we can see in this lead, it has widespread ST elevation. And also we can see widespread PR segment depression. Here we can see PR segment depression and widespread or diffuse ST segments elevation. And also we can see T inversion. If the acute pericarditis is a little prolonged, we can see T inversion in other leads. Also, as we can see in this ECG, we can obviously see widespread ST elevation in these leads and T inversion in AV or V1 leads. We can see T inversion and also widespread PR segment depression we can see in this ECG, which is the ECG of a patient with acute pericarditis.